Good morning, everyone. Thanks for coming. Appreciate seeing everyone. Today, we're lucky to have our chair, Dr. Monica Kraft, present to us, and I will turn it over to Dr. Bierkens to introduce her.
Good morning, everyone. Welcome to Grand Rounds. Today, we are honored to have Dr. Monica Kraft, our System Chair of the Department of Medicine. She joined Mount Sinai in July of 2022 and was previously the chair of the Department of Medicine at the University of Arizona College of Medicine in Tucson, as well as the Professor of Medicine and Robert and Irene Flynn Endowed Chair of Medicine. Prior to joining the University of Arizona, she was the Charles Johnson Distinguished Professor of Medicine and Chief of the Division of Pulmonary, Allergy, and Critical Care Medicine at Duke University Medical Center. There, she was also the director of the Duke Asthma, Allergy, and Airway Center as well. Dr. Kraft has published extensively in the area of adult asthma and chronic obstructive pulmonary disease. Specifically, her research interests include the mechanisms of innate immune dysfunction, inflammation and infection of asthma, as well as the evaluation of personalized and precision approaches to asthma therapy through clinical trials. She was also the principal investigator for the All of Us program at the University of Arizona. Dr. Kraft's work has appeared in such journals as the New England Journal of Medicine, Journal of the American Medical Association, The Lancet, the Journal of Immunology, American Journal of Respiratory and Critical Care Medicine, and Journal of Allergy and Clinical Immunology. Her work has been continuously funded by the NIH and the American Lung Association for over 25 years, and she has been a member and chaired several NIH study sections. She just completed her term as a member of the National Heart, Lung, and Blood Institute Scientific Advisory Council. In 2000, Dr. Kraft received the Presidential Early Career Award for Scientists and Engineers, awarded by President Clinton at the White House. She has also been awarded a Distinguished Career Award and the Elizabeth Rich Award for Mentorship from the American Thoracic Society, a major professional society for pulmonary critical care and sleep providers, where she also served as president from 2012 to 2013. She received the Arizona Bioresearcher Award of the Year in 2019 and is a council member of the Association of Professors of Medicine. We are incredibly lucky to have her as our chair and speaking to us today. Please join us in welcoming her.
Oh, thank you. What a nice introduction. I wish Mom was here to hear that. So I'm going to share my screen. Can you all see that? Okay, perfect. Well, thank you for inviting me. It's great to be in front of you all today. So I'm going to talk a little bit about asthma and a few other things. These are my disclosures, really around some research support and some consulting that I do with specific pharma companies to really get an understanding of the asthma pipeline. It actually really is informative, and have access to trials. So today I'm going to talk about some new areas of asthma pathobiology, but then really to discuss precision-based approaches to the treatment of asthma. Many of you who take care of asthma on the inpatient service think of it as, well, we just give them a bunch of steroids and bronchodilators and hope for the best. But the nuances really happen in the outpatient setting, to be honest. So I'm hoping that this will pique some interest among our trainees. And if anyone would ever want to come spend some time with me in clinic, please do. I think it's a great time to be in the field. We have lots of cool tools and therapies to offer our patients. But I thought I would start with a case. So this is a patient I took care of at Duke, 38-year-old woman with severe persistent asthma on intermittent oral steroid therapy who presents with increasing shortness of breath and wheezing. She was diagnosed with asthma at age 22 and it has at least one hospitalization per year since her diagnosis, as well as several exacerbations treated as an outpatient, was intubated once, has been on oral steroids intermittently, and has the comorbid conditions you would expect to see in a patient with severe asthma, gastroesophageal reflux disease, allergic rhinitis with history of nasal polyps, depression, and osteopenia. She has daily symptoms of shortness of breath when she's not having an exacerbation with really limited activity. She uses albuterol, which is the short-acting inhaler, about 4 to 5 times a day. And I do believe she has been adherent with her regimen. That's a whole nother topic. So this is her problem list, which you would expect to see in a patient with severe asthma. She also has aspirin sensitivity, meaning it causes rash and wheezing. So she has what we call Samter's triad: asthma, nasal polyps, and aspirin sensitivity. And she's on a medical regimen that wouldn't surprise you. She's on methylprednisolone. She was at the time when she presented to the ED. Medrol is another form of an oral steroid other than prednisone that I sometimes use. I find patients sometimes actually respond better to methylprednisolone. She's on high-dose fluticasone salmeterol, montelukast, albuterol, ipratropium nebulizers, and albuterol metered-dose inhaler, omeprazole, of course, for GERD, loratadines, and antihistamine, fluticasone nasal spray, calcium vitamin D, and back then she was on alendronate. Married with 3 children, 2 dogs, outside cats, office work with no exposures, and she's a never smoker. Mother had asthma and atopic dermatitis. On physical exam, she had prolonged expiratory phase with moderate air movement and diffuse expiratory wheezing. Her biomarkers, which we'll talk a little bit more as the talk goes on, she had peripheral eosinophils at 350 per microliter, which are elevated. Usually the normal is around less than 150. And exhaled nitric oxide is a way we can measure inflammation in the airways, and that's 40 parts per billion. Anything above 20 is abnormal. And her IgE level was 50, which isn't very remarkable. It's in the normal range technically. This is her chest X-ray. You can appreciate, I hope you can see my little arrow here, flattened hemidiaphragms. Lung fields look fine. Cardiac silhouette's okay. Trachea is midline. So nothing particularly remarkable other than the hemidiaphragms perhaps. And we were able to get some lung function tests. So this is the forced vital capacity. So this is as much as you can exhale in 6 seconds. So we compare it to reference, which is corrected for age, height, and gender. So she's at about 78% of her forced vital capacity. Normal is 80 and above, so not bad. But where it gets really concerning is her forced expiratory volume in 1 second. Those of us sitting around here, we should be able to get about 80% of our exhaled breath out in the first second. You'll notice she only got about, she got much less. She's at 48% of predicted. Her ratio is 53%. So this ratio suggests airflow limitation, difficulty getting the air out, and this low FEV1, less than 50% predicted, suggests severe airflow limitation. So what is asthma? It's a very heterogeneous inflammatory respiratory disease. It's actually the most common respiratory disease in the world. It affects over 350 million people and 25 million in the US, carries a huge economic burden. Around 80, these are older data, the only data that are available, 80 to 82 billion, that's billion with a B, due to emergency department visits, hospitalizations, medication costs, and lost productivity from work and school. So the symptoms are pretty straightforward: chest tightness, cough, wheezing, shortness of breath. And you can see what happens to the airway here. So we have a little cartoon here with a normal airway. You can see there's a lot more smooth muscle in the asthmatic airway, and the airway itself is constricted. And there's these little cells here lining the opening of the airway is the airway epithelium. And I'll talk a lot about that today. That's very inflamed and a very active participant in inflammation. So all of this goes to lead to airway narrowing, that bronchoconstriction that causes the symptoms patients present with. There is no cure, and it can be fatal. So I'm going to switch gears and talk a little bit about some research interests having to do with asthma and airway disease. And these are my research interests: airway biology, mechanisms of inflammation and innate immunity, microbiome and asthma, biomarkers, genetics, genomics, and precision medicine, and translational approaches. And today I'll talk a bit about airway biology, some mechanisms of inflammation, and then some biomarker precision medicine approaches. And at the end, I have some observations I want to talk to you about of what I've observed so far here at Mount Sinai, and for any other questions. So I'm going to start with surfactant, which you might wonder, why would I start here? Most of you might think of surfactant when it comes to babies who have respiratory distress, to reduce surface tension. That's exactly right. That function is carried out by part of this huge lipoprotein complex, really by surfactant proteins B, C, and the lipid portion. Now, there are also well-known host defense properties of surfactant carried out by surfactant proteins A, which I'll talk mostly about today, and D. And then hopefully I'll convince you that there's some anti-inflammatory properties, specifically of SPA, that are relevant to asthma. Because normally these two concepts, SPA and asthma, have not been linked. It's a very large protein. It's an octadecamer. It looks like a bouquet of flowers that are formed from monomers that form trimers. It's a very large, sticky protein. And the monomers have these domains relevant to function. For instance, the collagen domain is responsible for non-covalent oligomerization, receptor binding, We'll spend some time today talking about the lectin domain, which is our favorite, which is important for carbohydrate and lipid recognition and also pathogen recognition. So our 30,000-foot hypothesis is that one requires an adequate pool of functional SPA to have normal lung function, but that in the settings of low SPA or dysfunctional SPA, that contributes to the presentation of asthma. So the question is, how did we get here? So a long time ago, I like to say when I was a pup, I was at National Jewish Health following my fellowship at Colorado. And we started a program of bronchoscopy-based research where we could actually do bronchoscopy in a very safe way and obtain samples from the lung from patients with asthma in this case and healthy participants and look at how they function in the laboratory. And specifically, we would brush the sides of the airway to get those little airway epithelial cells. We can do what's called bronchoalveolar lavage, where we put saline in, take it out. You can look at a lot of mediators and proteins in the lung. And then we also can do very small biopsies that are about the size of a head of a pin to look at airway structure. And so we can take these cells and culture them in the laboratory at what we call it, these are the epithelial cells in particular, at an air-liquid interface. So what happens is they differentiate, they form cilia, mucus. They look a lot like they do in the airway. And what's fascinating is if you take these cells out of the human airway, they behave differently even in the lab compared to normal cells. So this gives us a way of really being able to understand how the epithelial cells in the asthmatic lung handle insults, because that epithelium is sort of the first line of defense. So many years ago at National Jewish, we were very interested in the role of infection in asthma because we know infections like viruses, and in this case, Mycoplasma pneumoniae, cause asthma exacerbations. So we went ahead and took our cells from bronchoscopy, cultured them in the lab. And if you focus your eye on the right side of the slide, the closed bars here, we exposed the cells to Mycoplasma pneumonia, that's MP. And these are the asthmatic cells here on the right. And you can see that MP infection, the Mycoplasma infection, caused significant increase in MUC5 AC message. So MUC5 is a mucin protein there's too much of it in the asthmatic lung. And this is why sometimes asthmatics can die of their disease. Their airways get full of this stuff. So you can see Mycoplasma causes a significant increase in MUC5 AC. One of the ways of doing this translational research is we can actually, out of this lavage, we can extract SPA. There's enough of it in the airways to do that. So we actually extracted it from a normal participant, or several normal, and we actually exposed the cells to normal SPA before the infection. And you'll see that MUC5 was very much reduced. However, the asthmatic situation was a little different. When we extracted the asthmatic SPA and used that before Mycoplasma infection, it didn't really do as good a job. And this last condition here is really to rule out the presence of an inhibitor. It was a mixing experiment. So it gave us a glimpse that maybe asthmatic surfactant protein A is not as good at really quelling inflammation compared to normal. So in the meantime, I moved to, as this research was just starting, I moved to Duke University and had the wonderful opportunity to meet Jo Ray Wright. I don't know if any of you may know her. She was the dean of the graduate school at Duke. Spent her career doing a lot of great work in the surfactant space. So we met, hit it off, and also she was very involved in ATS, American Thoracic Society leadership, so we got to work together there. And she left us too early. She left us at age 56 due to breast cancer. And so she's our spiritual leader of this program, and you'll see more why we think that. But she, I feel very honored and privileged to have met her. So at the time when we moved to Duke, her lab actually did an interesting experiment that got us very excited about this SPA asthma link. So she was looking at mice who are SPA deficient. And she challenged those mice with OVA, which at the time is a very common asthma model. And what she saw was this robust T2, we call it type 2 or eosinophilic inflammation in the lung of these mice. And so you can see there's increased eosinophils here in this SPA. This is the SPA knockout OVA condition. You can see interleukins 4 and 5, which are also part of this allergic eosinophilic inflammation we see in human asthma. And then of course, panel C is IgE, which we associate with allergy. So this was a key study because it kind of put together some observations we'd seen in humans that maybe there's an important link between SPA and asthma. So we asked that very question. Now to get at this, we look at animal models as well as human cells in our lab, try to go back and forth from mouse to man, because obviously mouse asthma is not human asthma. But we can look at asthma a few ways in a mouse model. We can use OVA, which I talked about. That's sort of an old school approach. We can do house dust mite, which is probably the most common. You challenge mice with house dust mite, you can get an asthma phenotype in the mouse. And then we also look at an IL-13 exposure model, because interleukin-13 is also an important cytokine in human eosinophilic allergic asthma. It's responsible for bronchoconstriction. It has effects on smooth muscle. It has effects on mucin that I was talking about earlier, and actually has effects on mediators that can cause collagen to be produced in the lung and cause this airway remodeling. If you've ever seen these patients with asthma that have very low lung function that does not reverse well with bronchodilators, we think of that as an airway remodeling. So we use an IL-13 exposure model too. So this is a busy slide. I'm going to take you through it. So this is a group of SPA deficient mice challenged with interleukin-13. And really, if I'm going to take you through and show you that these SPA deficient mice really had an exuberant, what we call allergic or eosinophilic inflammation. So here, if you look at this column here, this is the SPA deficient mouse with IL-13 exposure. You see lots of total cells in the lung. You can see lots of eosinophils and neutrophils actually compared to the wild type. You see this MUC5AC again, the mucin message. PAS score is actually the mucin protein, so it's elevated. And then other things such as KC, which is mouse interleukin-8, eotaxin, which is a typical mediator in the asthmatic lung, and interleukin-6. So this huge reaction when these SPA deficient mice are exposed to IL-13. So when you look at their lungs, you can see why. You can see that in the wild type situation, this is saline, exposed to IL-13, all this pink staining is mucus. But when you look at the deficient mouse and see the IL-13 exposure, you can see lots of pink. And I promise you, we did not cherry pick these images. And so with either an IL-13 model or an OVA model, you see this PAS score very high in the SPA deficient mouse, again, suggesting a very exuberant response to whatever we challenge that we think can cause an asthma phenotype. The good news is you can give SPA back and actually decrease the mucus, which is shown here on the left, and eosinophils on the right. So that's good news. However, mouse asthma is not human asthma. So how do we get at this in the human condition? And so I talked a little bit about the airway epithelial cell model that we use. And we do it via bronchoscopy, where we can get these really the first to 4 generation epithelial cells. You can also look at nasal epithelial cells, and you can do brushings, and they can often be a surrogate for lung epithelial cells, obviously more accessible than doing bronchoscopy. And then you can even look at these distal cells, because surfactant protein, by the way, is produced in the distal part of the lung by alveolar type 2 cells, but also throughout the airway by club cells. And it's been shown to be in the sinuses and in the gut. So as part of its host defense function, you can imagine those are important mucosal surfaces to be present. So we looked at our human cells. So I'm going to go back and forth mouse to man a little bit and expose them to interleukin-13. And you can see in this case, interleukin-8 increased. And down here in this panel, MUC5 also increased. If we expose those cells to functional SPA, you can see that IL-8 goes down and MUC5 goes down. So normal SPA actually does a good job at quelling the inflammation we see associated with asthma. So the question is, how does it work? So this is distilling down lots of experiments and time. We looked at a number of factors that are really responsible for asthmatic inflammation at the cellular level, and mediators that we discovered that seem to be modulated by SPA are, there's one called STAT3, and it's an intermediate signaling entity that is responsible for increased mucus, eosinophils, etc. So it's important for asthmatic inflammation. So we took our asthmatic cells and we exposed them to IL-13, and then we looked at how quickly STAT3 was activated. And you can see in the asthma setting, it's phosphorylated there. You can see the band. Interestingly, in non-asthma cells, you don't see any STAT3. And then when you add SPA, you can see STAT3 decreases, so that it's not as activated or phosphorylated. This is just to complete the experiment. STAT6 is also a really important mediator and responsible for the mucus that you see in the asthmatic lung. And in fact, interestingly, SPA didn't do much at all for STAT6, whether it was in the asthmatic condition or the normal. And so we validated this in many more participants, and also looked at this in our animal model. And so we think SPA acts as a STAT3 inhibitor. But there's a little more to the story in that we found an interesting paper, it's pretty old now, that suggests that there's a rephosphorylation of STAT3 that goes on due to IL-6. And you may have noticed I pointed out IL-6 is increased in that SPA deficient mouse. And not to get too much in the weeds, but IL-6 interacts with its receptor and comes together with epidermal growth factor receptor to cause this rephosphorylation of STAT3. So we think it's an ongoing cycle. So right now we're trying to figure out, does SPA focus really inhibit the IL-6 portion of this or the STAT3 portion? And we think it's probably more likely the IL-6. And again, just showing you that in an SPA deficient mouse that's exposed to IL-13, you can see an increase in an IL-6. So IL-6 is certainly around. And that if you inhibit IL-6 prior to IL-13 exposure, you see some nice decreases in the mucin message as well as the ataxin. So IL-6 appears to be part of this inflammatory cascade as well. Well, the issue is, though, humans don't run around with SPA deficiency. They have maybe some lower levels. We've shown in obese asthma, but they have some SPA. So why is SPA in asthma dysfunctional? Is it just a level issue, or maybe is there some genetic reason? And so to explore this possibility, we genotyped our patients. The SPA is made up of SPA1 and 2 peptides. And there are certain regions of the proteins where there's an amino acid change associated with the polymorphism. And these are the regions for SPA1, position 50 of the collagen domain, position 219 of the lectin domain. In SPA2, position 91 of the collagen, and you'll notice position 223 of the lectin domain, where there's a substitution of a glutamine for a lysine. And if you carry 2 copies of the glutamine, if you have the glutamine in your SPA, you have 2 copies of the major allele. A lysine is the minor allele. And the minor allele is present in about 10% of the population. Interestingly, about 30% of African American patients or people. And so that's an interesting observation, because in general, asthma can be quite severe in African Americans. So we thought, well, let's go ahead and take a look at whether this particular allele has any relevance to readouts we care about in asthma. So we looked at lung function, FEV1. And you can see this is the homozygote major allele CC, the heterozygote, and the minor allele AA. And you can see lung function's a little lower, actually, in all comers, and in asthma as well. And in fact, if we look at this asthma control questionnaire, which is a questionnaire that captures symptoms and lung function, the higher the number, the worse the asthma control. You can see that those asthmatic participants who carried 2 copies of the minor allele had much worse asthma control. So we got to thinking that maybe this portion of SPA2 is important for these asthma outcomes we care about. And so we actually were able to look at the SPA function in the lab from these patients with these particular genotypes. And this is looking at the percent suppression of MUC5AC after mycoplasma infection of epithelial cells. And you can see that the major allele does a pretty good job, heterozygotes in the middle, and the minor allele doesn't do well at all. So in fact, it looks like there may be some genetic reason for dysfunction of SPA in the lung relevant to asthma. So we asked the question, can smaller peptides of SPA be used? Because SPA is this big sticky protein, you can't really put it in inhalers. And so can we design these small peptides that span that region of position 223 and use that maybe as a therapeutic? And so that's where our company Receto was born. You'll notice Ray is named after Joe Ray Wright, and Ceto is Latin for calming. We figure nobody ever is going to want this name. No trademark issues. It's our particular name. And I co-founded the company with Julie Ledford, who's a PhD scientist that I met at Duke. She was in Joe Ray's lab for a period of time, came and worked in my lab, and then we moved to Arizona. And she is an associate professor in the Department of Cellular and Molecular Medicine, and certainly a wonderful independent investigator in her own right. But this MD PhD marriage is really an interesting one because she's very translational, and so am I. And so, but we come at this from slightly different vantage points. And so it's really exciting to be able to do this with her. And so again, focusing on this lectin domain, and just a couple of slides showing you that, in fact, when we do the same kinds of models we used with full-length SPA, if you expose SPA deficient mice to house dust, and in fact give them these peptides back, whether they're 20 or 10 amino acids, you can see a nice reduction in eosinophils and a nice reduction in mucus. So some of the same readouts we saw with the full-length protein, we can see with the peptide. Now, these data got us pretty excited because if you know anything about drug development in asthma, this is one of the ways that drugs are looked at, because this airway hyperresponsiveness is is a fundamental characteristic of asthma. So if you have asthma and you go out, let's say the weather's a little chilly this morning, you take a deep breath, it causes bronchoconstriction and wheezing. That's airways hyperresponsiveness. I think of it as airway twitchiness. And so in this model, we actually were able to give mice methacholine, which is something we do in humans as well, to cause bronchoconstriction, so this increased airways resistance. And when we give the peptide, you see this nice reduction in airways resistance. So we were super excited about that. And in fact, when we looked at our human cells, you can see that when you expose our human cells, our asthmatic cells, to the peptides, you can see either 10 mer or 20 mer, you can see a nice reduction in MUC5 compared to what we see in normals. So we think that SPA replacement is novel in that it does seem to modulate this type 2 or allergic inflammation. It looks like the efficacy of the peptide, at least for the readouts we care about in asthma, seems to be as efficacious as the full-length protein. One of the challenges we've come across is SPA can be degraded in the lung pretty easily because there's a lot of proteases, enzymes, et cetera. So we're now tweaking these peptides and producing these mimetics. And that's really where Rosito is going, is to look at the mimetics and see how they do with regard to really modulating asthmatic inflammation. And so we've just received some phase 2 funding from NIH to look at aerosol development, toxicity, and some more pharmacology because we've identified our lead. And so we hope that this next couple of years will get us through this, what we call the valley of death, where drugs go to die, and we'll be able to have an IND submission at the end. We also think that there may be some other directions for this. We found some efficacy in SARS-CoV-2 infection, which I won't talk about today, and we have some other diseases we think that this SPA peptide could be useful for. So it's been a really fun journey, sort of labor of love, to know that something maybe that we've talked about in the lab for years, because it's several decades of work, may actually benefit a patient one day. All right, so I'm going to switch gears and talk about human asthma and precision-based approaches and how asthma therapy has really changed in the last couple of decades. Because we know now that there's not a one size fits all, and this is not unusual for asthma. This is common in most chronic diseases. There's a lot of heterogeneity. And so there are a lot of different characteristics. It can be the time of the asthma, a time of onset, the exacerbation history, symptoms, lung function, kind of inflammation, goes together to really form what we call a phenotype. And so the idea is we want to understand these asthma phenotypes so that we can really practice personalized or precision medicine. And so a phenotype is observable properties of an organism produced by interaction of that between the genotype and the environment. In asthma, it can be based on clinical characteristics, triggers, general inflammatory process, but it's really this endotype that we care about. This is the mechanism driving those phenotypes, because that way, if we know what that is, then we can really design or provide an appropriate treatment. So in 2022, we divide asthma into two big buckets: type 2, non-type 2. Sounds pretty simple, I know. And there's some subphenotypes under there. But type 2 asthma is probably the asthma you know best, associated with eosinophils, has good response to corticosteroid. But there's different kinds of type 2 asthma. There's an early onset, which has strong history of atopic disease. And you've heard of this atopic march, oftentimes starting with atopic dermatitis as a baby or a toddler, moving to allergic rhinitis, moving to asthma. That's the atopic march. And it can be mild or severe, and it can be exacerbated by obesity. And usually eosinophils are a prominent cell. But there's this other kind of type 2 asthma, like the patient I presented today, that comes on a little later in life. And lots of eosinophils, not a lot of allergy, interestingly. But tends to have a very high preponderance of sinus disease, usually severe from the outset. And this is common especially in women who can really present with a very difficult asthma to treat. And obesity is quite prominent in this phenotype, and certainly the phenotype is exacerbated by obesity. And then there's this non-type 2 asthma, which is the other 50%. And this is probably the biggest unmet need. There are different kinds of non-type 2 asthma, but basically there's no eosinophils. So that's the difference. It doesn't respond well to steroids. There's a linkage to obesity. You may see neutrophils because of infection. You can also see due to environmental exposures like ozone pollutants, cigarette smoking. And so this is sort of a little schematic looking at type 2 versus non-type 2, and these are the different subphenotypes under here. So this allergic asthma is that early onset we talked about. There's actually a late onset and a very late onset type of type 2 asthma as well. It's not allergic. This is exercise-induced asthma. Exercise can exacerbate any kind of asthma, but it can be its own phenotype. And I remember at Duke and at Arizona, I would see athletes referred to me because, especially elite athletes, who were having symptoms at very with very high performing athletes would have symptoms, and obviously causing a lot of trouble in their athletic careers. On the non-T2 side, you can see there's smoking related, neutrophilic infection, and then there's this type of asthma that doesn't have any inflammation at all. It's all about structural changes in the airway, too much smooth muscle, collagen, things like that. And obesity, you'll see kind of straddles between the two, because obesity can be its own phenotype of a non-type 2 asthma associated with high interleukin 6 levels, interestingly. And but it can also make the type 2 asthma worse. So I kind of had obesity straddle the middle. So how do we figure out what kind of asthma a patient might have when you see them? There's some biomarkers at our disposal. Some are ready for prime time, some aren't. Sputum eosinophils is a great way to look into the airway, but it's just unfortunately not a clinically available test. My lab doesn't do sputum processes, so that's great, but that doesn't help most of our patients. We can use this exhale nitric oxide. Remember I mentioned in our patient, hers was 40 parts per billion. So you can measure it very easily in the clinic. That happens at the Respiratory Institute. And it's actually thought to be interleukin 13 driven inflammation. We can look at blood eosinophils, of course, IgE, like we saw in our patient. Allergen skin testing is really important because the IgE level alone isn't enough. You need to do either skin or blood testing to look for specific allergens and put it together with the clinical history. That's key. There are some biomarkers under development that I can talk about more if you're interested. Urinary bromotyrosine, the Cleveland Clinic group is advancing this, looking at eosinophilic inflammation. Club cell secretory 16 is something we're looking at in our own lab, as well as others as a biomarker. And eosinophil peroxidase, which is the enzyme that eosinophils really produce when they're activated. And the Mayo Clinic Scottsdale group is looking at this as a point of care biomarker you can measure with a nasal swab. So that would be really nice to have in the clinic. Now, the good news is in the type 2 asthma space, all these red boxes are actually treatments that are approved. And you'll notice they target specific inflammatory pathways in the airway. There's IgE, omalizumab. There's therapies that target interleukin 5, really important for eosinophil survival. IL-4 and 13. This one here, TSLP, is thymic stromal lymphopoietin. It's produced by the airway epithelial cell. I just call it TSLP, a lot easier. And so you can see lots of opportunities in the type 2 space. So very, very, it's really nice to have those options. And just, I'm going to mention some names. The information about the dosing is really not that important. And you would think about using these biologics in patients, let's say, who are on high dose inhaled steroids, maybe long-acting beta agonist combination, like our patient, who are having exacerbations or really poor asthma control, despite looking at, trying to give them the very effective medication, making sure you take a look at their sinuses. And if they're on a sinus regimen, treating their reflux, all those comorbid conditions we talked about with our patients, looking at depression, sleep apnea. So if you've done those things and they're still having trouble, that's when you send them over, or even before that, send them over to your friendly pulmonologist or allergist, and we can help you with this and think about these biologics. So you've probably heard about Xolair. That was the first biologic that came out. Targets IgE, takes it out of circulation. And it's really for patients who have lots of allergies. And now we're finding that if these patients have allergy, have an exhaled nitric oxide above 19.5 or 20 parts per billion, and elevated peripheral eosinophils, they're more likely to respond. So we're using these biomarkers to identify phenotypes, but then also predict response to treatment. So then, of course, along the lines of IL-5, that's a cytokine really important for eosinophil survival. We have actually 3 biologics, and you may have seen these on TV. Nucala, and it targets IL-5 itself. Sincair or reslizumab, which is an IL-5 inhibitor, And Fasenra or benralizumab is an IL-5 receptor inhibitor. So you may have seen these. And these are for patients who have elevated blood eosinophils, not necessarily a lot of allergy. And then dupilumab or Dupixent, you've probably seen that one as well. There's a lot of direct-to-consumer advertising these days. I'm amazed. This biologic inhibits 4 and 13. So the best patient to receive this would be somebody who has allergy, but also has an elevated exhaled nitric oxide, because we talked about how that's an IL-13 driven biomarker, and an elevated eosinophils. Now you'll notice these are all in the T2 or the type 2 space, the eosinophilic inflammation space. We have a new kid on the block. This is the latest, Tezspire or tezepelumab. It inhibits this TSLP that I mentioned, which is very high on the inflammatory cascade, and it improves exacerbations, lung function, and symptoms in patients with high eosinophils or even low. So this is the first biologic that's really been put out there for type 2 low or non-type 2 asthma. So that's exciting for people like me because we don't have as much to offer for asthmatic patients in that space. And because you can appreciate by this graph, there are very few red boxes. Those are the approved, the blue ones are under construction or under development. So not as much out there for the non-type 2 severe asthmatic. So just a couple words on PRECISE. This is a clinical trial that we are doing, and Mount Sinai is a center. And this is a precision-based approach to a clinical trial. It's a 10-center group funded by the NIH, and these are all. That's where everybody is. And you can see we're here. We're in a partnership with Denver with National Jewish Health, and Linda Rogers is the key person here at Mount Sinai. I was with the Arizona group and wrote part of the grant, but I'm so thrilled that PRECISE is here at Mount Sinai, so I get to continue working on the trial. And the reason it's so interesting is the idea is to identify novel therapies that work in biomarker-defined subgroups. So we really want to understand what patients are going to respond to which therapies, and can we figure that out under the umbrella of a clinical trial? And it's using what we call an adaptive platform design. And this design has been used by oncology for a long time, but it's really the first in the respiratory space. So the idea is a patient gets extensively phenotyped, just like I'm showing you with lung function, symptoms, biomarkers, all that good stuff, exacerbation history. Then they are randomized to different interventions with the hypothesis that they are likely to respond, but then they'll be compared to a group that's not likely to respond. And they go through a 4-month treatment period. And then after a 2-month washout, they can go into they can receive another intervention and then another one. So they can get several interventions as part of a trial, not just one versus placebo. So in my opinion, I think if I were a patient with severe asthma, that would be attractive to me because I could get several different treatments. And so the outcomes are lung function, symptoms, and exacerbations, really more focusing on lung function as the primary. So this is just a schematic about how it would work. There's a 2-month run-in, 4-month treatment period, a washout phase, re-randomization based on biomarkers to another treatment. Then usually you'll get either 2 treatments, active treatments usually, and then usually 1 will be placebo. And there's lots of symptoms and lots of biomarkers collected in terms of symptoms, spirometry, blood, eosinophils, neutrophils, all of these things you see here, DNA, RNA, PBMCs, exhaled nitric oxide, looking at sputum as well, exhaled breath condensate, and CT. So a very rich repository has been developed as part of this trial. And these are the interventions, which are not currently approved for asthma, so they're very different. This anti-IL-6 has been repurposed from the rheumatology space. And remember, I think I may have mentioned there's an obesity phenotype of asthma, a non-type 2, that's associated with metabolic syndrome and high IL-6 levels. So we think that's the type of asthmatic who would respond. Imatinib is a c-KIT inhibitor that's been studied in asthma, and we think those who have lower eosinophils will respond. This is a food additive, a medium-chain triglyceride that's produced by Nestle that has weight loss benefits and anti-inflammatory effects, especially in those patients who have exhaled nitric oxide levels greater than 15 parts per billion. Bronchovoxome is a bacterial lysate that has been approved in Europe for years to ward off colds, upper respiratory infections, that actually has some benefit in asthma, especially in those who have higher eosinophils. And then cavasonstat is an enzyme, is a mediator that inhibits an enzyme in the lung and the epithelium that's associated with bronchoconstriction, and there's a genotype specific response. So you can see these are very different treatments compared to what we have now. And really, we're doing a series of phase 2 trials to look at what may have benefit in our severe asthmatic cohort. And so basically, if you see a patient who has severe asthma that's really on high dose inhaled steroids and long-acting beta agonists and not doing well, they can get in with due to low lung function, poor symptoms, or at least one exacerbation in the last year. So please, if you have these patients, we'd love to hear about them. We're actively recruiting. We're up to about halfway done. We're going to be recruiting about 400 patients or so, and we have really enrolled about half that so far. So we're making progress. So our understanding of the biology of asthma, I think, has really improved dramatically. And with that, we have treatments we can offer patients that really are targeted to specific kinds of inflammation. So I really feel like we're practicing precision medicine, which is exciting. But asthma is complex, and it's not a one-size-fits-all disease by any means. And so an understanding of this heterogeneity is really critical to be able to practice precision therapy. So I want to say just a couple words about the All of Us program, because it was mentioned I was the contact PI. Speaking of precision medicine, this is a study that plans to recruit 1 million patients, diverse patients nationwide, and these patients will undergo whole genome sequencing, and those data will be put together with their electronic health record to create this amazing repository that scientists all over the country can ask questions about genetic origins of disease. And so it's a focus on participants as partners. We've been doing this since 2015. It's a longitudinal design. There are multiple data types: electronic health records, surveys, baseline physical measurements, biospecimens, and genomics. And it's ultimately going to be a national open resource for all. There are security and privacy safeguards. So I'm a participant in All of Us as well, in addition to being the contact PI, because one of the value added is that we get genetic results back, the actionable genes, as well as information on pharmacogenomics, meaning I'll get information as to whether I have any specific mutations that affect drug metabolism, which is a good thing to know. We're bringing this to Mount Sinai, in that we've received a supplement with the University of Arizona to start recruiting patients for the All of Us program. And so we've also submitted an application to be an independent recruiting site. We think the All of Us program will be a great complementary program to the Mount Sinai Million, which is led by Garesh Nadkarni and Alexandra Charney, because the Mount Sinai Million also endeavors to recruit 1 million Mount Sinai patients who will undergo a whole exome sequencing, and again, put it together with their electronic health record in what we call kind of a low touch protocol. And so the All of Us is a little more in depth. And so we think we can actually really co-recruit for these studies and really create this amazing repository to really understand genetic origins of disease for our patients, gene bioenvironment interactions, as well as a resource for scientists around the country. So very excited about that. All right, so just a couple slides to finish up on my journey here. And I think we've already heard a little bit about this in the introduction, so I won't spend a lot of time on this. I'm a daughter of immigrants. I trained in the West Coast, went to UC Davis undergrad because my dad thought Berkeley was too dangerous. UCSF for medical school, Harbor UCLA for residency and chief residency, and University of Colorado for pulmonary critical care. Spent some time at National Jewish Health, which is really amazing that Mount Sinai has this relationship with them. I feel like life has come full circle. Was able to sort of develop into a physician scientist during my fellowship and beyond, and run an adult asthma research lab as well as a pulmonary physiology unit. And I've always maintained a clinical practice. I think it's really important, especially as a physician scientist, to keep your hand a little bit on the clinical, so because I think they inform one another, and it can be a very satisfying career path. And then moved on to Duke to direct the Asthma, Allergy, and Airway Center, eventually became vice chair for research and then division chief, as you've heard. And then moved to Arizona in 2014 for 2 reasons. One is to work with a world-class asthma group out there, and also to build the Department of Medicine, which was going into a relationship with Banner Health to create the 5th largest nonprofit health system. And so we did lots of recruiting and building, over 200 faculty, 8 division chiefs, quadrupled NIH funding. It was a really satisfying time. and I think trained me well for this experience. Between my National Jewish Health, Duke, and Arizona experiences, I feel like I have been well trained to take on this wonderful challenge of leading this amazing department. And so I want to tell you about some observations I've had so far, just in the few months I've been here. And I'd like to come back in the spring and do more of a state of the department. But I wanted just to tell you some things that I've noticed that we're working on, because I think communication is really important. And we're thinking of many different ways to communicate with the many faculty that we have in the department. So one thing that's really come through is wellness. I mean, you know much better than me. You all had a tremendous response to the COVID-19 pandemic. I hear that when I hear the talks about all that went on here, I mean, I'm just, amazed. But I do think we're trying to now kind of dig out of this and sort of move on to the next phase. But I do feel like it's affected faculty wellness. I feel it when I talk to faculty. And so with my wonderful Vice Chair for Administration, Brian David, we're going to be looking at some facets of wellness, including compensation for our clinical and research faculty, because we don't want to lose any of our talent to New York institutions or anywhere beyond New York, that's for sure. We're also looking at mentorship, making sure faculty feel like they're supported. And Jenny Lynn is the systems director for mentoring, who is going to be expanding her reach to the whole system. So regardless of job description, the idea is that faculty have at least one mentor, if not a mentor team, to help guide them so they don't feel so isolated. I think this is done more commonly in the research arenas, less so in the clinical. Also, there'll be opportunities for leadership training. There already have been, but we'd like to expand those. And working with Naomi Shah, who's our new System Vice Chair for Faculty Affairs, in that arena, along with career development, making sure everyone understands the value of promotion, and of course, satisfaction in the workplace. And so that's a big issue, because as the health system wants to expand beyond Manhattan to Queens, Brooklyn, Long Island, Staten Island, New Jersey, we also have to make sure we have good workflows in the clinical arenas we have to be sure faculty are supported. And so working with Beth Raucher, who's the System Vice Chair for Quality and Clinical Affairs, as well as the system division chiefs on these issues, for sure. And making sure we have a place or a voice in the recruiting of faculty around the health system, really to build that outstanding Mount Sinai brand. So that's a work in progress as well. On the research arena, I have the opportunity to work with Ben Chen, our Systems Vice Chair for Research, to look at our research portfolio, of course, along with our division chiefs. And let's move us into the top 10 of Blue Ridge rankings. So Blue Ridge is a ranking system for departments, and we're number 13, so we're really close. And so we've got some wonderful recruits coming down the pipeline, so more on that. Also to see innovation as a career path. Hopefully you got a little glimpse of that from what I have talked about today, that you can take discoveries and think about how you could benefit a patient, whether it's a therapeutic, a device, a wearable, anything. There's a lot of opportunity, and Mount Sinai is very well positioned through Mount Sinai Innovation Partners to move those ideas forward. Want to make sure that faculty know about these things. And also we're taking a lot of time to expand clinical trials. We'd love to have, we really want to go where the patients are and provide treatments and access to treatments for patients that may not normally have that type of access. And so I envision hubs all around our health system that have clinical trial space, staff, and ultimately trialists. So that takes me to training the next generation of academic physicians. That's really what we're here to do. And academic medicine takes a lot of different forms. Certainly you've heard from me, a physician scientist, but there's also outstanding educators, master clinicians, administrators. And so there's a lot of ways you can have a satisfying academic career. And I want to give a shout out to our amazing Systems Vice Chair for Education, David Thomas, who's been instrumental in sort of making this happen. And while we're thinking about training the next generation, we also have to make sure and think about our faculty recruits and really recruit a diverse workforce to effectively serve our community. And so Kirk Campbell, who's our Systems Vice Chair for Diversity, Equity, Inclusion, is working with me and as well as the entire department on these issues. And he also is an MPI of the NIH First Award, which is an opportunity to be able to recruit diverse faculty and provide resources in the research arena. And I know Ben and Lauren Pecorolo, they're also, Ben Chen, they're also part of this grant. And to really remember that we're part of a health system and not only a department. And so one of the challenges is how to communicate effectively with all of you. So clearly I'm doing a little of that today. We have a newsletter. I'm going to be sending out emails really like once a month is what I'd like to do, really highlighting some developments in the department. And then of course through division chiefs, you'll also hear about activities and events. But that's probably the biggest challenge, is to make sure that we get all this great information out to everyone. So I'll just say that I'm really thrilled to be here. The three missions are implicit. Research, clinical care, and education. Of course, philanthropy, the philanthropic support of Mount Sinai is fantastic. I feel like I have some good training in my past that has led me here, and collaborations in place. And so it feels like a nice fit. The training programs are outstanding, and it's really an amazing institution. And I want to thank you all for the warm welcome you've given me. And I can't be happier to be able to lead this outstanding department. So thank you so much for your attention.
Great. Thank you, Dr. Kraft. That was terrific. Great. That was terrific overview. And Monica, there's already some questions in the chat.
Okay. Great.
Where is it? So there's one here. You talked about several commercially available drugs. What is the cost, and are insurance plans paying for them?
Oh, great question. That's one of the challenges. Biologics are very expensive. And so that's why we want to be very careful about who we really identify as candidates for these drugs. In general, for the most part, we've been able to get insurance approval, but it takes prior authorization. It's not simple. And sometimes we can't. And so, but I'd say that's more the exception rather than the rule, because we really try to make sure these patients are the appropriate candidates. What will happen, what I'm interested in seeing what will happen now that we have 6 biologics at our disposal, I think carriers are going to be more stringent about which ones we get to choose. Similar to the inhalers. If you've been involved in inhaler choices, sometimes you don't get a choice. It's what the insurance plan covers. And so I'm a little concerned that the carriers will go that route with biologics. And the whole point of biologics are to pick the right one for the right patient at the right time. And so therefore this is a challenging area because of cost. And that's why I think new therapeutics that can position themselves more as pre-biologics are really needed, that are cheaper. That's where I think I would like to see the field go.
Great. Andy, I'm going to read the next question, Andy, but see if you can unmute. Otherwise, I can ask Francine to do that. So Sakshi Dua has an interesting comment here. Not a question, but an aha moment. Julie Ledford was a postdoc in Bev Kohler's lab at UNC when Sakshi was a pulmonary critical care fellow there on her research year. She knew her well. Nice.
Cool. I love that. Thank you. And, I know Bev well. We were on study section together. And so that's wonderful. Thank you for telling me. Yes, she is amazing. I'm really lucky to have her as a partner in this endeavor that we're doing. So thank you for letting me know.
Francine, can you unmute Dr. Stewart? Oh, no, she can. I'll read the next question while we see if she can, Andy. Another question. My question is whether phenotyping at the imprecise stage where it seems to still be is informative for more than half of asthmatics that have mild to moderate asthma and whose treatment, inhalers, leukotriene modifiers, differs little.
Right, good question. So what I didn't talk about as much today is there has been some of this phenotyping done in the mild to moderate group. And about half of the patients don't have a lot of eosinophils, interestingly. And so I'm part of a different asthma network called AsthmaNet, or it was, it's over now. And we did a study in the mild to moderate group and found that for patients who did not have a lot of eosinophils, that tiotropium, which is a long-acting muscarinic agonist, actually had a benefit in that group versus an inhaled steroid. Now that has not gotten into the guidelines yet. So it's hard for me I actually, of course, have a lot of faith in that study, and I think it's true, and it demonstrates heterogeneity even at the mild to moderate phase. So I think our phenotyping is going to move back, and I think as we get more sophisticated about how we can do it, that's really the key. Just as an aside, I'm working with this fabulous company in Denver who has this next-gen sequencing approach to phenotyping where we can get a much more in-depth immunologic phenotype, but also look at the microbiome as well. Because I think that's a whole nother layer of complexity that can modulate inflammation. And so I'd love to see or have the ability to do much more in-depth phenotyping to understand the patients with asthma across the spectrum.
Andy, you're unmuted, Andy.
All right, thank you, Monica. That was fabulous. I want to ask another sort of valley of death question, but not the one you talked about. Another valley of death is really smart medical students and residents and clinical fellows somehow getting the idea that they couldn't possibly do biochemistry, physician, scientist kinds of things. So I'd love to hear your story of when you decided. Were you born with a pipette in your hand? Did you major with drug design in college? Or when did you get the bug, and how did you get the bug?
I always, like lots of medical students, liked science, right? So, in high school and even in college, actually, I'd had some really key research experiences. One of those summer experiences, working with the pharmaceutical company Syntex in Palo Alto before they became Burroughs Wellcome and Glaxo and all these things. And so got to spend some time with some really, really wonderful investigators. I think it's the people that you meet when you have these experiences and you look at what they do and how excited they are about their careers that really got me excited. And ultimately, I didn't end up in the chemistry space. I was a chemistry major as an undergrad. But I thought maybe there was a possibility that I could like this path. And so I picked a fellowship. For me, it was fellowship. I did a little bit of research and residency, but that's not so easy to do back then. Now we have actually options. And I think we're putting in that STAR grant. I know Ben and I were just talking about that, to offer residents a research path. And of course, the residents here already do research, which is fantastic. But if there's a thought that you might consider that path, even if you're not sure, really figuring out a training program that gives you time to learn investigation is key. And it doesn't necessarily have to be a PhD. I thought about getting a PhD, but I didn't. And so I was able to learn investigation really through some early experiences in college, medical school, and residency, but really it was fellowship that crystallized that, because it was in the area that I was really interested in pursuing. So I kind of got the potential bug, but it was really about the people I met and setting myself up for experiences where if I thought maybe I would want to do this, I'd want to position myself to really figure that out, because I always knew I was going to be a clinician as well. And I had that if, let's say, the research life just wasn't for me.
Thanks, Andy.
Great.
Barry, Dr. Kohler has a comment and a question. So fabulous work. Congratulations. Do you think there was selection for the AA phenotype? And if so, what was the likely reason? What's fascinating about this AA, this genotype, is in other contexts, it can be quite beneficial. So when we look at, for instance, other infections like viruses and bacteria, having the lysine in that position is actually a good thing. So for asthmatic inflammation, it isn't so good, but for infections, it is. And that may have been what this selection was about. And so I find that sort of, you have to put it in sort of evolutionary context, if you will. But so the problem is maybe it fought off infection, but didn't do enough for the inflammation we associate with asthma. And that, because of our environment and where we live now with exposures to allergens, et cetera, turned out to be the dominant force. So that's a really great question. We think about that a lot. And Dr. Greenberg put a question in about, actually, at the same time you're talking about the microbiome. So have microbiome studies in the lung and the GI tract or elsewhere gone anywhere?
Oh, yeah, absolutely. That's a whole nother talk, so I didn't get into it. But we actually looked at this in asthma via bronchoscopy, and with a protected brush and making sure we didn't contaminate any different compartments, and found that the microbiome in asthma, as compared to allergy alone, as compared to the healthy situation, very different. And there are specific taxa that are pathogenic that are in the asthmatic lungs. So so we found that to be quite informative. I think now we're actually seeing that specific bacteria or taxa can actually affect drug metabolism and affect steroid metabolism. And so in the sense of increasing the breakdown of steroids in the lung, which of course would not be a positive thing for an asthmatic patient. So there may be something more than just, obviously innocent bystanders of these alternative bacteria sitting in the lung, but they actually may have a functional consequence. So it's still a pretty young field, but it's moving along. It's definitely not dead.
Right. Thank you. That brings us actually directly on time, so really appreciate it. So I want to thank Dr. Kraft for coming today and sharing not only her expertise in asthma, but a little bit of her personal story of how she got here. And now you can see why we are all lucky to have Monica as our system vice chair. So thanks, Dr. Kraft, for coming and presenting today.
Thank you so much. It's great to be here. Have a great day, everyone.
Have a great day, everybody. See ya.
Bye-bye.